Hello everyone, myself is Dr. Abhishek, who is a mentor of an study MRCS. As we know, we are conducting a marathon series regarding about the general surgery part B, OSCE stations. So I think yesterday class you guys discussed about an anatomy. So in this session, this is second series where you're going to talk about the surgical pathology. As we know that in OSCE, we have mainly we have 17 stations, among which we have divided them into one and the knowledge stations and as well as and the skill stations. So the pathology, our session today falls under the knowledge stations, where we have two main pathology stations. One with the pure pathology, and the second station will be pathology with an additional little microbiology station. Okay. So and main motto of these station in OSCE is to check your the reasoning, the knowledge capabilities and the reasoning capabilities. Okay. In this today's session with this agenda, we are going to discuss about how we're going to answer in the OSCE station. So we're going to approach each station with regarding to the pathology. So we're going to answer to an examiner, and we are going to discuss in detail about a gist of all the topics. Okay, we may not cover entire everything, but we are going to cover the important topics and important points you're going to have to remember before going on exams. And we have certain do's and don'ts at the end, and as well as certain pearls which may have help, which will help you for your future sessions. Okay, so we have totally divided them into 9 sessions. Basically, first will be about your framework and the pathology task how we're going to approach it with the neoplasm. Second, we're going to talk about the stations related to cell injury inflammations in the wound healing. The third stations will be about the breast pathology and the reporting. The fourth will be about the GI malignancies. The fifth will be about the skin cancers. And 6 stations will be about cardiovascular system pathologies like aortic stenosis and infective endocarditis. The 7 stations will be about the bone metastasis and orthopedic pathologies like your fractures and the primary tumors or pathological fractures. So 8 stations regarding about the vascular pathology, which includes ulcers, which may be an arterial or an even the neurological or even the venous ulcers, the gangrenes and ischemia. The 9 stations will be about an endocrine relating to the parathyroid and as well thyroid gland. In the last stations, we're going to discuss about certain few questions regarding about these stations and as well as certain points which can help you in the future exams. So with this, we'll start with the first station. So regarding about pathology test stations, as I said, this comes under the knowledge stations, where the heat station, we have only 2 pathological stations. So heat stations which carries 20 marks, and you have only 9 minutes to approach it. So 1 minute you to read the stem, and as soon as you enter into the stations, since it's a purely knowledge based stations, you don't have any other than your examiner. Okay, so he's going to throw you some questions and you want to say the answers. Okay, so how this pathology stations usually will be. So the examination of pathology will revolve under the 4 main things. Okay, so one is you will have gross specimens, which may be which may be a gross actual specimen itself, or it may be the gross picture graph itself. Most of the time it will be a photograph of the gross specimen, or there may be a photograph of your histological slide. Okay, then we have any clinical pathological lesions that will be shown, or there may be an actual histopathological report itself you will have, and most of the time it will be histopathological report rather than your photographs, and most of the time and you will have other radiographs which might help you for the arriving at the diagnosis. Okay, so most of the questions in and around will be in these specimens itself. Okay, so that's why each stations, when you approach each topic in pathology, make sure you're going to cover all this. What are the gross features? What are the microscopic features? What is your clinical features? How are you going to stage it? How are you going to manage according to the stage? And what are the complications associated with this? Okay, so these are the certain things you have always keep in the mind while approaching the each stations. And while you're answering also, you should make sure that you're going to cover all these topics. Okay, so how the marks has been distributed here, most of the time it open always with the first line definition. For example, if I go with that of for example, for the malignant melanoma, so they starts with define malignant melanoma, okay, or define the condition like this, or define abscess. It always starts with a 1-line definition, and always make sure that you have to read the standard definition which has been given with your study material. Okay, and which will goes with the most of the time our reference will be from the Bayesian law, so you should always follow the strict 1-line definition of it. Okay, then second, you're going to use only correct terminologies. There will be certain points that will be allocated for. If you utter the terminology, you will be allocated with certain marks of it. Okay, so you should always use a correct terminologies. You should not list out the other things, okay, which should not beat around the bush in other sense. Okay, should always come to one point. Third, regarding about always when you mention about the classifications, the grading, the staging system, will always have an extra marks. And regarding about the route of and spread, when you're talking about and the malignancies, and regarding about and the management, you should always, since it's the pathological stations of knowledge station, where in the pathology we're going to talk more about the pathology rather than the management, but we should always answer the management if at all if the question comes regarding to a according to our pathology related management. You should always say rather than the clinical thing. Okay, so with this background, we'll start with, and that is what I said, this is an answer framework. Start with the one line definition, followed by the gross features with the microscopic descriptions, read about the microscopic and the histological features, classify, grade and staging. If so, staging, we always follow a TNM staging. That's very important stages for a neoplasm, so that you're going to be thorough with that and start wills. If at all if it's a neoplastic stations, you're going to ask about the route of spreads, okay, whether it's a locally malignant or lymphatic or hematogenous or transcelomic. Then clinical relevance regarding about its complication, the management, the behavior of the certain regarding that pathology. Okay, with all this background, we'll start with carcinogenesis. So this is a general topic. Okay, so what I'm going to talk now, this can be covered with the most of the neoplastic stations. Either it can be from the parotid, or it can be from your gut cancers or the esophageal, or even in your any other skin related cancers. Always remember the background remains, or the basic remains the same. Okay, the carcinogenesis itself cannot be in a station, but it can act as a basis for many of the other stations. Okay, so what are the things you have to remember when it comes to any neoplastic stations? Always remember the cause of it. Okay, the carcinogens, which is responsible for the development of that particular cancers. Okay, so the risk factors, in other words, or the means of which the cancer can be spread, okay, or acquired. So the carcinogens can be in the form of chemicals or physical or viral, or sometimes it may be of inherited genetic mutations. So if at all, if I talk about in general, the chemical carcinogen, smoking, most of the time, even in case of a lung cancer, the smoking will be of a risk factor, major risk factors. Aromatic amines in case of the bladder cancers, asbestosis in case of mesotheliomas and bronchogenic carcinomas. So these are the actors in chemical carcinogens. The physical agents which are leading to cancers like UV rays, okay, which leads to skin cancers, most commonly the squamous cell carcinoma, basal cell carcinomas, ionizing radiations. Okay, the viral, which is HPV viruses, which leads to your cervical and anal cancers, Epstein-Barr viruses, which brings about the Burkitt's lymphoma. We have an hepatitis B virus and hepatitis C virus, which leads to development of hepatocellular carcinoma, H. pylori, which is most important risk factor for the development of the stomach cancer. So these are the certain things are viral carcinogens. Then we have some of the inherited, the gene mutations, which and leads to one development of the cancers like BRCA in case of and the breast cancers, FAP and HNPCC in case of gut cancers, colorectal cancers, they're mostly involved. So coming to the genetic basis for each of the cancers, most of the time the cancers develop because of these mutations in these group of genes. We have something called an oncogenes. Okay, we have normally the oncogenes like KRAS, HER2 and MYC genes. Normally they are in inactive stage. But once these carcinogens enters into the body, they activate these oncogenes, and that is responsible for the formation of the cancers. Then we have a tumor suppressor genes, where they will be having a P53 and APC genes. These are very important in case of your development of the cancers, where they lost their functions. They undergo some mutation and they lost a particular function. That itself and leads to development of the tumor. Then we have DNA repair genes. So all these genes plays a very important role in case of when the cell undergoes a cell cycle. There are certain stages where each cell cycles will be under the control of these genes. Okay, so if there is these genes can't get under mutation, so there will be unregulated proliferation of the gene of the cells that may lead to development of neoplasias. Okay, DNA repair genes like mismatch repair, HNPCC, That's an example for it. And we have a multi-hit accumulation derived progressions. So we have in multiple stages, these mutations can occur. So there may be mutation of for example, we have an adenoma carcinoma sequence where most of the gut cancers will be developed by this, where the mutations of APC gene followed by and the KRAS activation followed by APC gene mutation followed by an P53 loss of function, which leads to development of a cancer. Okay, that's called some multi-hit accumulation drives the development of the cancer. Okay, so the cancer is basically, it's a multi-step genetic disease. Activated oncogenes plus inactivated tumor suppressors accumulates until the growth become the autonomous, and the autonomous unregulated, that's called unregulated proliferation of the cell which lost their normal functions with development of the cancers. So in any of these neoplasia stations, you always remember what is the carcinogens, what is the genetic basis of that particular cancers. Okay, coming to the principles of neoplasias. So neoplasia can be of either the benign one or the malignant one. So what are the things which differentiates between the benign and the malignant? This is the most basic one, correct? So any of the neoplasias, like for example, parotid tumors, most commonly we discuss about the pleomorphic adenoma, which is a benign one. Whereas when you talk about any of the skin cancers like squamous cell carcinoma or the basal cell carcinoma, they are the malignant ones. Now, when you say it is a neoplasias, these are the basics which you have to determine in each station whether I am discussing about the benign one or the malignant one. Based on this, you can answer your questions. For example, if you're talking about your station describes the pathology in a way that these growth will be very slow, which are expansile in nature, where the tumor will be encapsulated. On a histological pathological examination, the cells are well differentiated. Okay, and on a clinical examination, there is no any metastasis, or the rate of recurrences are very rare. So all these are the features which goes in favor of benign tumor. Then you have to think that we are going to discussing about the benign tumor in that particular station. Okay, if at all, in other hand, if the pathology report goes says in such a way that there is a rapid growth of a particular tumor which is of infiltrative in nature, there is on clinical examination which found to be very irregular, there is no any definitive capsule. Okay, on an histopathological examination, there are certain cellular atypic features, there is increased mitotic figures, and they will be having an anaplastic features. Okay, and they will be having, they say that there is an history of an recurrence and as well as a metastasis. So then you have to decide that you're going to discuss in terms of malignant tumors. Okay, so how to define malignancies? Malignancies is defined by the capacity to invade and metastasis, and not by the size or the growth rate. Okay, it's about the ability of a cancer to invade the other organs. That is how you're going to say that particular cancer will be a malignant. It's not about the size nor about the growth rate. Okay, that's a very important thing. So once we diagnose with the patient or the clinical scenario is about the cancer, then we have to stage it and grade it. So what is difference between the grading and the staging? So the grading is nothing but you're going to say how the tumor looks like, whether it is related to that of the parent tissues, whether it will be well differentiated or poorly differentiated or moderately differentiated. So that says how bad the tumor is. Okay, that's called as a grading, how it looks like. Whereas in staging, that's very important. Staging is where how far the tumor has been involved in the body. So it reminds that whether it has been locally spread or it has been distantly spread, whether it's involved the lymph nodes or not. Okay, so it's about the staging. So when you talk about and among the grading and staging in the tumor stations, always remember the staging is a very important one. Okay, because that's how we're going to manage each of the tumors for the management. Okay, so that's why the staging is very important. Most of the tumor stations, we follow this TNM staging system. So what is this TNM staging? So the T stands for the tumor size and the depth, N stands for the nodal involvement, that's a lymph node involvement, and M stands for the distance metastasis. Okay, based upon the permutation and combination of these subcategories, we are going to give a staging of the tumors. Okay, so once you determine the stage and grading, then we're going to look after whether it has been, if it is malignant in nature, if it's been metastatics to the other organs, then you're going to look after what are the route of spread. Okay, so certain tumors have a certain route of spread. For example, most of the sarcomas, as in general, so they have an hematogenous spread. Like your connective tissue tumors, sarcomas are nothing but the connective tissue tumors, like the bone tumors. Okay, so they have an have an emetogenous spread. It's not like all or none phenomenon. The most of the time you can remember that. And most of your carcinomas, okay, they have the lymphatic invasions, okay. And certain the tumors, they don't have hematogenic or lymphatic, but they are very locally malignant in nature. For example, your basal cell carcinomas, they found to be or if we call as an rodent ulcer. So they have an highly aggressive, locally aggressive in nature. That's called local invasion. And certain tumors have transcelomic spread itself, okay, like in through our cavities where they spread, okay. So that's about the route of spread. So when you're talking about neoplastic stations, think about in the grading, staging, and as well as route of spread of particular station. Okay. So with this, so once you have staged it, then in case of pathology, most of the time we talk about the tumor markers and immunohistochemistries. So I mean, this comes under the diagnosis of the particular tumor. Okay. So the tumor markers are nothing but these are the certain chemicals which are present in the blood, which found to be an increased associations with the presence of the tumor in the body. So to be looked after as in some of the few examples like carcinoma embryonic antigen, they say if at all the increased level of CEA will have an high association with the colorectal and the pancreatic tumors, CA 99 for the pancreatic and biliary tumors, CA 125 for the ovarian tumors, prostate specific antigen for the prostate cancers. It's not like that if it's a PSA is elevated, it's a prostate cancer. It's always, if it's not like CA 125 is elevated ovarian, you should always, it's clinically correlated with this, okay. AFP, alpha fetoprotein, which determines the presence of hepatocellular carcinoma and germ cell tumors, and with the beta HCG, which is responsible for the germ cell tumors and as well as the trophoblastic tumors in case of ovarian tumors, and that comes under the beta HCG. Then in order to the line of differentiation, whether it has been which tumor the particular the growth looks like, for that so we have the upgraded pathological exam. What we do is use of immunohistochemistries. So we have certain stains which we're going to use in order to identify that particular line of tumor. Cytokeratin for those tumors which have an epithelial the carcinoma of an origin, S100 for the melanoma and the nerve sheath tumors, CD45 for the lymphomas, vimentin for the sarcomas, thyroglobulin for the thyrofollicular cells, and PLAP and OCT4 for the germ cell tumors. Okay, these are the certain few examples for using of immunohistochemistries. So with this background of the cellular neoplasias, so we're going to talk about one more topic regarding about the general pathological stations, which includes the cell injury and the death. This can be again a separate topic, or it can be of the adjacent topic to one another in the pathology. Okay, so cell injury and the death of a cell can be of either in the two forms. Either it can be in the necrosis form or in an apoptosis form. So what is this necrosis? Necrosis basically, it's in the simple words we can say it is the homicide. Whereas an apoptosis is a suicide one. Okay, the only single cell which undergoes the death by itself. Okay, that's a programmed cell death. That's called as an apoptosis. Whereas a necrosis is a pathological injury. Okay, it's the death which induced by surrounding organs, surrounding tissues, and there will be the loss of cellular integrity, okay, that leads to development of necrosis. So coming to the difference between the necrosis and apoptosis, most of the time necrosis will be pathological event, apoptosis can be of the physiological event. So in what sense it can be physiological? Like if at all, whenever the cell enters into one cell cycle, if a cell has undergone a mutation, so the genes have undergone a mutation, for example the P53 has undergone a mutation, then there will be checkpoints. Once it identified that there is a mutation of P53, then there will be activation of this apoptotic genes which are responsible for the development of apoptosis, so that it prevents for the cell to not become a cancerous cell. Okay, that's called an apoptosis. So the extent, most of the time the necrosis will be often the group of a cell, the tissue is which undergone an necrosis, whereas an apoptosis most of the time it will be a single cell event. Membrane, that's very important, that's what differentiates between necrosis and apoptosis. The membrane will be intact in case of an apoptosis, a cellular membrane, whereas in necrosis there is a loss of cellular membrane. So there will be a loss of, because of the damage to cellular membrane, there is a loss of an ion homeostasis. As a result, what happens, there will be the inflammation which sets in, and there will be an activation of a certain mechanisms inside the lysosome, release of lysosomal organelles, and that causes a death of a cell. Okay, that's how the necrosis occurs. The energy in necrosis is of an ATP independent, whereas in its apoptosis, it's an ATP dependent, it's energy dependent process. Okay, At the end of each process, in case of necrosis, will end up in having a tissue with a loss of cellular differentiation, which is on an examination of HND, we'll see what is called as full of histology. In histology, will is called as a bluish hue. Okay, we can't able to differentiate the cellular structures. In case of apoptosis, we end up in having an apoptotic bodies, with what we call. Okay. So coming to the talking about a necrosis, the necrosis can be of the different types. Okay, so we have something called coagulative necrosis. So in this where the description will be like the architecture of the cell will be preserved, but not to a certain extent which can be identified. Okay, so the architect will be preserved, it will be formed in nature. The classical side where we can get about the coagulative necrosis will be often solid organ like an kidney, or following an kidney infarct, or following an MI in case of an heart. Okay. Now, in case of liquefactive necrosis, this can occur whenever they don't have proper supportive tissue trauma, as in case of the brain and central nervous system, where they have a brain infarct. Okay, following an CVAs. That's how we have identified liquefactive necrosis. Caseous necrosis is one of the most commonly we'll come across it. It's called as a cheesy or the granulomatous necrosis. Most common example will be a tuberculosis, where we have the granuloma with the central caseating necrosis which occurs there. Fat necrosis, as the name indicates, where the tissues which made up of more often fatty tissues, like in case of the breast or in case of the pancreas. Okay, where the saponification of the lipases which occurs, that leads to development of fat necrosis. Then we have the gangrenous. Gangrenous is the type of a necrosis which occurs due to the loss of blood supply. We call it an ischemic necrosis. Is most of the time it will be gangrenous in nature. So we are going to, in future slides, we're going to talk about and what are the difference between dry and the wet gangrene itself. So basically, if it's an ischemic necrosis, most of the time it ends up with having a gangrene. Most of the time bubble and the lymph. Okay, so that's how we are going to identify. There's something called fibrinoid necrosis, also one more type, which usually occurs in case of the blood vessel. For example, with a patient with a malignant hypertension and all, the blood vessel wall, okay, that undergoes a necrosis called fibrinoid necrosis. That's again another one type of necrosis. Coming to one inflammation, that is one of the basic part of pathology, where we have an acute and the chronic inflammation. So the inflammation is basically the body response to any form of tissue injury. Okay, if it's an acute one, it's called an acute, or if it's delayed for the longer duration of the time, and there'll be a low grade inflammation, that most of the time comes under the chronic inflammation. So the granulomatous is also type of the chronic inflammation. Okay, so the important features what you have to remember, if it is an inflammation station, if we are talking about an acute stations, like in case of an pancreatitis, acute pancreatitis, when you see an exam pathological slide, what will be our features, what is histological features, then you have to remember, so it's an acute inflammation stage. So the cell of injury will be often neutrophils. That is a main identification cell for the acute inflammation. So you can say that neutrophils are present in the particular slide. Okay, and what are the different, we have both cellular stages and vascular stages for an acute inflammation, and we have a certain clinical features like pallor, rubor, tumor, dolor, functional lysis. Based upon keeping these as a basics, you can answer the each acute inflammation stations. Coming to the chronic inflammation, so we have in the plasmas are the lymphocytes or the macrophages. Mainly the macrophages will act as under the cell for an identification of the chronic inflammations under the histological slide. So they have an end up with either they become a chronic inflammations, or they end up in having in fibrosis, the tissues. So one of the example of chronic inflammation is the formation of the granuloma. So example can be of tuberculosis, sarcoidosis. Okay, so the granuloma is nothing but where it's an the macrophages will be modified to form an epithelioid cells. Okay, they have a simply shaped nucleus, and they characteristically have chain cells. Chain cells are nothing but this multiple macrophages are fused together to form a single cell wall with multiple nuclei. Again, that are the characteristics of the granulomas. In case of tuberculosis, we have something called chain cell, that what usually will be having example for the granulomatous inflammation, central caseating necrosis, followed by they'll be having an epithelioid cells arrangement, and they'll be having the chain cells and peripheral rimmed by the lymphocytes. Okay, so the organized epithelioid macrophage is called granuloma. Causes can be of tuberculosis, Crohn's disease, sarcoidosis, presence of the foreign body in the for a longer duration of the time. Infections like leprosy can end up with having a chronic granulomatous inflammation. Coming to the wound healing and its complications. So based upon the any wounds that has to be healed either by primary intention or by the secondary intention. So what is primary intention? When the edges are being opposed, for example, the surgically incised wound, if you have sutured it back, then that skin will be healed by primary intention. Okay. Here the tissue loss will be very minimal. The mechanism how the wound healing occurs is by epithelial bridging mechanism. Okay. The scar what you want to get fit is a linear and fine scar. The chance of infections will be very low in case of primary wound healing. Secondary wound healing occurs whenever there is a secondary. Most of the time we'll leave the wound for secondary intention if there is an infection of the wound. Okay, until the infection has been subsided, we don't do one primary intent closure. So in secondary wound healing, it will be often the edges will be open or the gaping will be present. There will be a significant tissue loss, and the mechanism how the secondary wound healing occurs by the formation of the granulation tissue. Okay, the scar will be very large in nature. The chance of infections will be very higher in case of secondary wound healing. So there are certain factors which delays the wound healing, like ischemia, infections, patient's nutritional factors, patient having a certain comorbidities like diabetes, or patient who is on steroids or is immunocompromised, or if a patient having an habits like smoking and alcohol. So all the presence of the foreign body locally. So all these others, there are numerous factors that can delay the healing process. Coming to one end, we'll talk about the breast carcinoma for gist of it. Basically, it's a very important station, breast carcinoma. As I said, whenever you're talking about in each carcinoma station, you should know what is the definition, what are the types of breast carcinomas, what is the carcinogen, and how it spreads, and what is histological features and the management, staging and the management. Okay, so the definition can be of like this: the malignant proliferation of the breast epithelial cells. Okay, they are two major among we have different types of breast carcinomas. Among them, the most common will be of invasive ductal carcinoma, which is of non-specific type, is the most commonest one. Okay, the types of breast carcinomas can be of the ductal carcinoma in situ, which is a pre-invasive or the pre-malignant one, where the basement membrane will be intact. There will be no breach of the basement membrane by the cancer cells. That's called the DCIS. Then we have something called invasive ductal carcinoma, which is no special type, not special type. This is the most commonest and invasive type of breast carcinomas. Invasive lobular carcinoma. Most of the time, lobular carcinoma will be of bilateral and multifocal in nature. Okay, lobular carcinomas, which is of less frequent compared to that of and the ductal carcinomas. Then we have other special types like medullary, mucinous, tubular. Based upon the histological features, you're going to describe this. But most of the time, when you talk about, we have two major types. One is a lobular one and the ductal one. Okay. Now coming to one, and we know the carcinogens for this, the breast carcinoma will be an BRCA gene mutation. Okay, that's the most important gene mutation which undergone. And once you have find out the pathogen or the carcinogen, then you're going to identify what is the staging and prognosis of it. Okay, so we are going to use this spread. Either it can be lymphatic spread, where the sentinel group of lymph node, the axillary group of lymph nodes are the first to be get involved there. If it's a hematogenous, they have in the medicine, the bones, lungs, and livers in the brain. These are the sites of secondary deposits. Okay, especially in the bones, they have a sclerotic deposit, lytic, both mixed. It's a mixed deposition, both lytic and as well as in the blastic deposition. Coming to the nodal status, that's a very important prognostic factor about the involvement of and the number of group of lymph nodes involvement. Then we have the regarding about the prognostic index. We have a Nottingham prognostic index that includes the size, grades, and nodal status of the tumor. Okay, so that indicates a prognostic factor of this. Now coming to one, how we are going to investigations in detail regarding, we are going to do one mammogram, we are going to do one and the HN. First start with the clinical examination, then you're going to start with the USG, then you're going to start with the mammogram, then you're going to take and the FNAC. Okay, so cytological examination that confirms the biopsy which is a definitive for a diagnosis of the breast carcinomas. The management, again, it depends upon the that's very important in these stations as breast carcinoma. We have to remember regarding about one is an immunohistochemistry, and as a second is to know about the receptor status. So we have something called two receptor status, whether this carcinomas are responsible, response to the tofen and the certain hormonal status of the tumor. That's very important that we want to talk, that we want to check in case of the breast carcinomas. Okay, so that's estrogen, progesterone status. So whenever in this station, most of the time we have an histological report. So what are the things you should look after whenever there is an histological report? First, the type of the tumor, they would have been mentioned there. Okay, the appearance of histopathological examination would be of look like an ductal carcinoma, the lobular carcinomas. Okay, then the grade regarding about and the Nottingham's prognostic index they would have mentioned. Then you have to ask about the margins, whether they have any clear margins or if there is having tumor sizes. Based upon that, then based upon the lymph node status, which is a key prognostic indicator in case of an and the breast carcinomas, the receptor status, that's very important. In the tumor stages, the receptor status is very important, like estrogen receptor status, progesterone receptor status, then HER2 receptor status. So this status helpful for us to treat the breast carcinomas. Then lymphovascular invasions, how exactly the tumors would have been spread. Okay, so that's how you're going to pathology will help us for the management of the breast carcinomas. Okay, so how it's going to help us for molecular studies by using histological slides. So if at all if you found that that particular breast carcinoma is of estrogen progesterone response positive, they have a very good response with that often using with a tamoxifen or aromatase inhibitor. Okay, in sense like tamoxifen or meloxifene. Okay, so use of these will lead to and the control of that spread of the particular tumor because they are hormonal response in nature. If at all if you found that there is an HER2 positive, okay, this is certain receptors which are present on this tumor cells. If they found to be of an Herceptin positive, then you're going to treat the therapy with that trastuzumab or Herceptin drug. Okay, so then we are going to use, and there's something called triple negative where they're neither hormonal response nor an HER2 response tumors. They have a very worse prognosis. In such conditions, we go for the chemotherapy with the certain chemotherapy drugs. Something called luminal A type where they are HER2 receptor, they are estrogen hormonal receptors responsive, but they don't have an HER2 response. So they are a very good prognostic indicators because they have a very low grade kind of in tumors. Now always remember, when you have a triple negative tumor of the breast, they have a high chance of going for the worst prognosis, okay, because they have only relied upon the chemotherapy because they neither response to the tofen hormones nor to the tofen or to drugs, receptor drugs. With this background of the breast carcinoma, so we have to talk about the gastric carcinomas. So in this gastric carcinomas, what we have to remember, what are the risk factors for development of the gastric carcinomas? So the risk factors can be of just a minute. So we have so many risk factors. Most of the time, the most common risk factors for development of gastric carcinoma will be our H. pylori infection, alcohol, smoking, okay, and use of certain amines, use of smoked foods, okay. So these are the certain most common risk factors for development of the gastric carcinomas. The thing what you have to remember in gastric carcinoma, we have three main staging systems. One is Lawrence, then we have Bowman's, and as well as we have WHO classification. Among the gastric carcinoma, the adenocarcinoma will be the most commonest one. The Lawrence divide them into two types. Either it can be intestinal type or the diffuse type. So that's how the Lawrence stage is it. So the WHO says based upon the histopathological examination like papillary, tubular, mucinous. Okay, that's how they say in case of WHO. Then we have something called Borman's. Borman's is basically when you do an endoscopic examination, you find how exactly the tumor looks like, grossly, like whether it's in fungating type, whether it's a polypodal type, whether it is an infiltrative type, whether it's an ulcerative type. Based upon that, the Borman's classification is that. So Lawrence is the most widely used adenocarcinoma of the adenocarcinoma staging for the gastric carcinoma. So we have intestinal, the diffuse type. Intestinal type usually will be occurs in case of the older age people. It will be of well differentiated one. Okay, well differentiated. They have a very good better prognosis. Whereas the diffuse type usually occurs in younger age group people. They have difficult to differentiate. That's why it's called a diffuse one. And if it's very largely involved, example for this, what's called is linctus plastica. What is linctus plastica? It's nothing but it's this type of tumor which involves the stomach. The stomach will look like the leather black bag. They lost its shape. That's because they are infiltrative in nature. That's called linctus plastica, and they have a very worst prognosis. This occurs usually in case of very young age people. Okay. The signet ring of the diffuse type produces a linctus plastica, which is nothing but the leather bottle or the leather bag appearance of the stomach. Coming to the route of spread, very important. These are the certain key features that you have to remember. So whenever the gastric carcinoma which have been spreads to left supraclavicular group of lymph nodes, that's called as another Trocher's sign. Okay, the fancy name for this is witch of nodes. Okay, and if at all if they have a transcelomic spread and involving the ovarian in case of the females, then there the tumor which get deposits there, it's called a Krukenberg tumor. Okay, then if at all if they are having an infiltrate to the surrounding skins and involvement of in and around the umbilicus to form an nodules, then it's called as a Sister Mary Joseph nodules. And then if at all if it's been get deposits in the pouch of Douglas, then it's called as a Bloomer's shelf. Okay, so these are certain eponyms for the spread of the gastric carcinomas. So here are the risk factors: H. pylori, atrophic gastritis, pernicious anemia, salt, nitrates, smoked food, smoking. So all these are act as a risk factor for development. Among all this, H. pylori, what you have to remember, because it's a viral carcinogenesis. Okay, so these are the certain few points that you have to remember in case of a gastric carcinoma. Same thing, we are going to use an TNM staging system. Based upon the TNM staging system, we are going to do a management. One more important cancer station, that's a colorectal cancer. We have a sequencing and staging system. Typical about the colorectal carcinomas are they have the mutations usually occurs in case they have a genetic basis for the development of the tumors. Okay, that's called as an adenoma carcinoma sequence. As we see here in this slide, so first there will be a normal mucosa. So the normal mucosal cell will develop into an adenoma if there is a mutation in the APC gene. Okay, if an APC gene, once the APC gene lost its functions, then the oncogene, that is KRAS, which activates. Then the normal, which is an hypoplasia, becomes a dysplasia now. Okay, so when the KRAS has been lost, because that's an oncogene. Once the tumor suppressor gene like P50 get mutated, this dysplastic cell will eventually end up in become a neoplastic cells. Okay, so that's how the adenoma carcinoma sequence, that's how it occurs, because of mutation in the sequence of the tumor suppressor genes and as well as the oncogenes. Okay, so the staging, why important about, that's one of the the rare factor about and colorectal carcinoma regarding about and the sequence. And second, you have to remember about the staging. In the colorectal cancer, of course, we use both TNM staging and traditionally we use a Duke staging system, additional along with the TNM1. So what is this Duke staging system? That's based upon the level of involvement of the tumor. If a tumor confined only to the layer of submucosa, okay, which is within the bowel wall till the submucosa, then it comes under the Duke stage A. If at all, if the tumor has spread into another bowel wall involving muscularis propria. So the bowel wall has 4 layers, right? So mucosa, submucosa, muscularis propria and serosa. If at all the tumor has extended till the muscularis propria, then it's called as B. Again, we have a B1 and B2. If it's not breached the muscularis propria, it's B1. If it's gone behind the muscularis propria, it's called as B2. Then again we have a C. Again we have a C1 and C2. If the tumor not only confined to the bowel wall, but also metastatized to the top on the local lymph nodes. Again we have a C1 and C2. Then we have a D. D is nothing but the distant metastasis. Okay, that's about the very important as well as an easy to remember the Duke staging system, which is used for the colorectal cancers. One important thing what you have to remember is that among the, why we are more worried about the Dukes, because that's what we use for the treatment of the colorectal carcinomas, especially if there is if the tumor has been across the stage C, okay, then that it triggers that we have to use a chemotherapy because it would have been involved in nodal. Okay, that's how we have to start with the chemotherapy along with the other mode of treatment. Okay. Coming to certain key facts about the colorectal carcinoma, as I said, it's in the genomic sequence. The carcinogen will be often, follow-up marker and tumor marker will be often CEA gene. If at all, if the colorectal cancers, if it's involving on the right side of the colon, most of the time the patient will present with anemic features. If a patient having on the left side of the colorectal cancers, then the patient may present obstructive features like large bowel obstructions. Okay, and we have to do this FIT to identify the presence of occult field of blood in the stools, and colonoscopy for the screening. Okay, this is the time investigation modalities for the colorectal cancers. Coming to the esophageal cancers, which is one of the most readiest one, and we have in two main types: squamous one, adenocarcinoma one. And nowadays, it's adenocarcinoma which is gaining a trend because of an unhealthy eating habits where there is an regurgitation. The GERD has become an high, so the GERDs will be predisposing further development of an adenocarcinoma, and this usually occurs at the lower part of an esophagus, lower third of an esophagus. Okay, squamous cell carcinoma occurs in case of the upper and mid of an esophagus. As we know, the lining of esophagus will be a stratified squamous non-keratinized epithelium. So the squamous cells undergoes a malignancy is there, that's called leads to squamous cell carcinoma. The risk factors for the upper third or the development of squamous cell carcinoma in esophagus will be smoking, alcohol, frequent taking of not drinks. Okay, so all this will leads to development of squamous cell carcinoma there. In adenocarcinoma, you have to remember the pre-malignant condition is called as a Barrett's esophagus. Because of the GERD, there will be the columnar cells which are present. Metaplasia of the squamous cells to columnar cells at the lower third of an esophagus that leads to act as a pre-malignant condition for the development of adenocarcinomas. Coming to skin cancers. Skin cancers can be of various types, but most of the time the skin cancers are malignant in nature. We have three main varieties. We talk about basal cell carcinoma, squamous cell carcinoma, and malignant melanomas. Each one has a different distinctive features, and each one can be of a separate stations. So coming to the basal cell carcinoma, it's also called a rodent ulcer. As we said in the previous slides, this very key feature of these basal cell carcinoma are they don't spread. Metastatic to the distant organ is very less. The distant metastasis is very less, but they are locally aggressive in nature. So the local spread of the tumors are very high. And the basal cell carcinoma, most of the time it occurs in the skin with the sun exposed areas. Okay, and it's a commonest among all the skin tumors. On a gross examination, we see there is a pearly rolled edges, and there is a telangiectatic thing. They have a locally invasive nature where they can malignant. Okay, that's called the basal cell carcinoma. Coming to the squamous cell carcinoma, which is of most of the time they present with an ulcerated forms or the crustated forms. They have a high chance of metastating to the distant organs, and most of the time they spreads via the lymphatics. Okay, and they have also having some of the pre-malignant skin conditions like acanthotic keratosis or the Bowen's disease. Genetical involvement will be present in case of squamous cell carcinoma. Coming to the malignant melanoma, as we said, the malignant melanoma will be tumor of melanocytes. So what are these? They are the pigment producing cells which are present in the skin layer. So that's about the malignant melanoma. Again, they have the pre-malignant conditions. So eventually they develop into the malignant melanoma. On an examination, there is something called ABCDE. What is this? Based upon the range. How are you going to differentiate whether the skin nevus is a malignant melanoma? If at all, based on the ABCDE criteria. If there is an asymmetry of the margin, if there is a borders or irregularity, okay, if the color variations are present, if it's a brownish or other color other than the brown, if there is a diameter, the horizontal diameter, if it's crossing more than 6 mm, or the evolution where they say the rapid increase in the size, rapid change in the shape of the nevus mole. So all these features which shows that the patient developing a malignant melanoma. Okay, they are the most aggressive form, and they have both lymphatic and as well as an hematogenous spread. So coming to the basal cell, they are locally aggressive. Squamous cell, they have a lymphatic spread. Malignant, they have both hematogenous and as well as a lymphatic spread. In malignant melanoma stations, we are going to talk about, and we have something called Clark's level of invasions. Okay, so then we have based upon the depth. Okay, then Breslow's thickness. We talk about the Breslow's thickness. That's nothing but the on an histopathological examination. If you see if the depth from the status granulosum. So the skin has 4 to 5 layers like stratum corneum, granulosum, then spinosum. Then we have the lucidum and the basal. So from the level of granulosum till where the depth of and the involvement presence of the melanocytes, you're going to thickness. Based upon the thickness, we have something called Breslow's thickness. That's one of the important prognostic factor that's used for the for in case of staging the management, even in case of a malignant melanoma. Okay. This is what we are talking about. So that's about an ABCD criteria. Then Breslow's thickness, very important prognostic factors, which is measured in from a millimeter from the granular level. Okay, based upon this Breslow's thickness, we want to decide about how much we are going to have in safe margins for the excisions of an and the malignant melanoma. Okay, central line lymph node biopsy, that's very important for the staging. Okay, that's about an malignant melanoma. And coming to certain pre-malignant lesions that can develop these case of skin cancers, like as I already said, the solar keratosis for the development of squamous cell carcinoma, Bowen's disease for squamous cell carcinoma, Marjolini's ulcer, that's nothing but the chronic non-healing ulcers. If they fail to heal, then we have to think about this development of marginal ulcer, especially in case of burns and all. They develop this marginal ulcer. These ulcers have an eye predisposed for the development of squamous cell carcinoma. Then you have the dysplastic navis for the development of malignant melanomas. Coming to certain few cardiac pathological stations, aortic stenosis, very important stations of cardiac pathology. We have an aortic stenosis, infective endocarditis. These are the two main stations we come across. So aortic stenosis, how do you define it? It's nothing but there is a decrease in the size of an aortic valve. Okay? That's known as aortic stenosis. So what are the causes of this aortic stenosis? We can remember like this. So first, it can be because of, in case of younger age group, this can be because of an the calcification of an the congenital deformed valves. For example, if it's a bicuspid valve, the undergo and calcifications leads to a decrease in the size of an aortic valve. Okay, that's called as that's one of the cause. Then in case of an older age group, because of a senile degeneration and the calcification, that's called dystrophic calcification of the aortic valve. In elderly patients can develop an aortic stenosis. Or if there's a calcification of already deformed valves, as in case of an rheumatic heart disease, where the post-inflammatory scarring, okay, that leads to smaller size of an the aortic valve, that's called an aortic stenosis. So coming to the, what is the pathophysiology with this aortic stenosis? So this aortic valve is a semilunar valve which is present between your left ventricle and the aorta. So if there is a stenosis, there will be no how the output from the left ventricle would have been decreased. As a result, there is no adequate cardiac output. Okay, so that's one pathology that we have to think about, and there is a decrease in cardiac output. So there will be increase in the end diastolic volume of the left ventricle. So that again leads to an increase in the afterload. Whenever there is an increase in the afterload, the heart cannot able to pump it properly, so that there will be a decrease in the blood supply to the top and the even for the heart itself. Okay, so that's are the different pathology for an aortic stenosis. Because of the defect in the cardiac output, so the patient have a SAD symptom. What is meant by SAD? SAD. S stands for syncope because of the decreased blood supply to the brain. Then angina because of decreased blood supply to the heart. Dyspnea again because of the congestion. Why the dyspnea occurs? Because whenever there's an aortic stenosis, there will be an increase venous stasis. I mean the increase in the pressure in the left ventricle because of the blood stasis in the vein in the left ventricle. So there will be backward pressure to the top and the left atrium, and because of that, and they'll be having a congestion in the capillaries of the pulmonary capillaries. That's why the patient may have an dyspnea. Okay, so the SAD symptoms are very important to determine the patient having an aortic stenosis. Coming to the criteria to say the patient has severe aortic stenosis, when you do an echo, you found that the area will be less than 1 centimeter square, or the pressure will be more than 40 mm, achieving the pressure gradient, or the jet velocity of the blood across the aortic valve if it's more than 4 meters per second. So these are the certain 3 criteria says that the patient had developed severe aortic stenosis. So clinical examination, since they have an aortic semilunar valve which is involved here, so the patient have the ejection systolic murmur at the aortic area, and we know this aortic murmurs are usually relates to the carotids and bending, leaning forwards. Okay, so this view again we are going to you guys are going to read in detail about in clinical examination stations involving cardiovascular systems. Okay, but remember, presence of ejection systolic murmurs radiating to the carotids is again a feature of aortic stenosis. Narrow pulse pressure, okay, having an apex beat, okay, they have an heaving apex. So these are the certain clinical features suggestive of aortic stenosis. coming to an endocarditis, infective endocarditis. So how to define infective endocarditis is nothing but it's the inflammation of an endocardial surface of the heart involving the valves. Okay, and that's called endocarditis. If it is because of an infection by certain organisms, then it's called infective endocarditis, where involves the valves and there's a vegetation of an organisms, presence of fibrins and platelets. Now, what are the organisms which causes infective endocarditis? Most common is Staph aureus. We have something called HAC group of an organisms where Haemophilus influenza, Acinetobacter. Then we have an Echinella, Cordens, Kinginella, Kingae, Cardiobacterium. Okay, these are certain organisms, HAC group of organisms which can develop. We have Streptococcus viridans after the dental work. Okay, if there is involvement of the prosthetic valves post surgery of the valve replacement, patient may have an high chance of developing an infective endocarditis, which will be caused by Staphylococcus epidermidis, which is one of the commensal of the skin. Okay, Candida can be there if it's immunocompromised. If at all, if these present, then you have to remove the valve. So for the diagnosis of infective endocarditis, we have something called Dukes criteria. Okay, so the Dukes criteria involves the major one and the minor one. The major, we have the two major one. One is we have another clinical criteria and as well as an investigational one. The blood culture. The blood culture should be positive at the two separate occasions, and the two separated occasions should be healed the same organisms which found to be here. Okay, which are highly responsible for the development of infective endocarditis. That's one of the one major criteria. And second is some clinical evidence of an involvement of an and the valves, like echo findings which shows presence of an and the development of new regurgitations or the valvular coaptations or the valvular collapse. So these are the major criteria, two major criteria. Minor criteria can be of development of the fever and high predisposing risk factors. For example, if patient is a known case of an RHD, rheumatic heart diseases, or if a patient is undergone a valvular replacement, this comes under or the defective valves. So those patients will come under the predisposing factors. Or if there's something called vascular phenomenon. Vascular phenomenon, as being seen, there is a presence of an oscillous nodules, Janvey lesions. Immunological phenomena will be the Janvey lesions. And all these are the criteria, minor criteria. Either you should have two major criteria with the no minor criteria, or with one major with the three minor criteria, or the five minor criteria. So these are some of the criteria should be present for the diagnosis of infective endocarditis. Okay, it's very hard to treat infective endocarditis because the valves are usually vascular. There will be formation of vegetations along the closure of the valves. Okay, the border of the valve. Sometimes it can also involve the endocardial surface of the heart. So the valve, if it is involvement of the valve, it's very difficult for the antibiotics to reach the valve because they are valveless in nature. And the bacteria itself, they forms a protective layer that's called a biofilm. Okay, so that there is a glycocalyx which prevents the entry of this antibiotic inside the bacterial colony. Because of this, it's very hard to treat an infective endocarditis, and most of the time we end up in having a replacement of the valves. What are the peripheral signs and complications of an infective endocarditis? We have something called Janvey. These are the hand lesions. Okay, so the Janvey lesions, like in case they are the painless erythematous macules, or the raised lesions that are present in the palms and soles. That's the Janvey lesions. That's because of the deposition of septic emboli. Oscillous nodules, it's are the immunological ones. They are highly painful in nature. They have tender spots at the pulp of the fingers. That's called oscillous nodules. They're because of the immunological depositions. Rot spots, when you do an retina examination, you can see the rot spots. Splinter hemorrhages in the nails. There can be certain questions like what are the hand signs expect in case of infective endocarditis. Remember, it's a splinter hemorrhages, Janvey lesions, and as well as an oscillous nodules. Complications of this can lead to valve destructions, where it can lead to regurgitation of the valve or the heart failure. Septic emboli can develop into a stroke and abscess. Okay, so that's what you have to remember. And coming to one more important topic in case of cardiac pathology, that or vascular pathology, you can say that's an atherosclerosis and aneurysms. What's atherosclerosis? We know that there is a thickening of an arterial wall by the deposition of the cholesterol or a lipid accumulations. Okay, there's a narrowing of the wall. It's called an atherosclerosis. Then what is the aneurysms? It's an abnormal dilatation of the blood vessel wall. It's aneurysms. So atherosclerosis, most of the time they have an Witchof's tried, where they have an endothelial injury followed by an venous thesis, and as well as there will be an deposition, hypercoagulable state. So all this will lead to formation of the thrombus or the plaque. there. That's called atherosclerosis, which occurs. The reason, the risk factor for development of atherosclerosis will be the smoking, which is an highest risk factor, hypertension, diabetes, hyperlipidemia. There's a time risk factors for development of atherosclerosis. Okay, complications based upon the site of involvement, that particular organ will be involved. Like it can lead to a CVA, it can lead to MI, it can lead to this atherosclerotic plaque can leads to an retinal artery end damage, or sometimes the plaque can develop into thrombus or get dislodged to form an emboli, or it predisposed to development of aneurysms. So coming to aneurysms can be of it's nothing but abnormal dilatation of the arterial wall. The arterial, we have three main arterial: tunica, intima, media, and adventitia. If all the three layers has been involved, and that will be thinned, attenuated to form another swelling there, that's called a true aneurysms. Whereas if it's neither involvement of any of these valves, just there's a dilatation which is covered by the granular layer, then it's called a false aneurysms. The false aneurysms usually occurs following a traumatic event, whereas the true aneurysms have a major other risk factors. Okay, so the very important part we have to remember is AAA, aortic aneurysms. That's abdominal aortic aneurysms. Most commonly occurs in case of an abdomen at the infrarenal regions. Okay, abdominal aorta of the infrarenal before the bifurcation into one common iliac veins. That's the most common where the abdominal aortic aneurysms usually occurs. Most of the time it undergoes an asymptomatic one. If at all, if there is a pain, pulsatile mass, and the patient, if it's ruptured, they present with a shock. And if at all, if it's an incidental finding, if you find that if it's more than 5.5 centimeters without any symptoms, then we have to undergo for the repair. If it's more than 3 centimeter without any symptoms, then you have to do one conservative line of management. If it is with symptomatic, then you have to go for another treatment. Okay. So what is the treatment? What are you going to do? It's called as an EVAR, that is endovascular aortic aneurysmal repair. Okay, endovascular aneurysmal repair, EVAR, but endovascular technique, what are you going to do? If it's a direct rupture, most of the time, 99% it's a fatal. The patient will usually die in case of abdominal aortic aneurysm. The main pathology in aneurysm is there's a cystic medial degeneration of the aortic wall, the wall of the blood vessel. The tunica media, especially the elastic degeneration, which fails, cystic medial degeneration occurs. So that's what leads to formation of AAA. Coming to an orthopedic pathologies, we talk about the bony metastasis, very important one. The bony mets can be of either the primary bone tumor itself, or most of the time it will be secondary malignance from the other primary sites which get deposits in the bone. So that's called as the bony mets. The 5 main primary sites of development of the bony mets are the breast, the bronchus, that's lung, then we have the prostate, kidney, and the thyroid. These are the 5 main organs which they have bone mets are more commonly present. Now coming to and among all this, the prostate in case of the males, the breast in case of the females are higher chance. Where does most commonly the bony mets occurs? It most occurs in case of the spine. In the spine, it's the lumbar region followed by thoracic one, or it can be, this is about an axial section, or appendicular. When you talk about this, most commonly occurs in the pelvis and the upper part of the humerus or upper part of the femur. These are the most common sites where the bony metastasis are most commonly occurs. So the bony mets can be of 3 different types. It can be of a sclerotic one, or it may be lytic, or the mixed, based upon the activation of certain the bone cells there. Okay, for osteoblastic activation occurs, the increased bone formation, sclerotic one. Example, prostate. If it is in the osteolytic or an osteolytic cells has been triggered, there will be increased osteoclasis of the cells, osteoclastic cells. Okay, so there will be an activation for osteoclast leading to the lytic bone lesions. For example, the primary mets from lung, thyroid, and kidney. The mixed can be seen in case of the mets from the breast lesions. Okay, so these are the things. This why important. This may produce upon development of pathological fractures. Okay, that's very important. So by trivial trauma, if a bone undergoes a fracture, that's called as a pathological fracture. Various reasons for the pathological fractures can be from osteoporosis till the metabolic bone diseases and the bone tumors. We are talking more worried about the bone tumors causing pathological fracture. For this, we have something called some Merrill's criteria. Okay, so based upon the pain, based upon the site of involvement, based upon the lesion type of lesions, we have something called Merrill's criteria. That's for management of pathological fracture, whether we have to do a prophylactic fixation or not. Okay, that's Merrill's criteria that you have to remember. The cause of a pathological fracture, as I said, can be of any of these things, like osteoporosis, most commonest one, metastatic one, multiple myeloma. Very important of multiple myeloma. In old age people comes with occult fractures or the low back pain. We should always rule out the multiple myeloma. Paget's disease, primary bone tumors. This primary bone tumors, based upon the origin, it can be of osteosarcoma if it's arising from the bone forming cells, and osteosarcomas are most common in the in and around the knee, either in the lower femur or upper tibia. We have something called Codman's triangle, that is an identification clinical feature of an osteosarcoma. Then we have Ewing sarcomas, which are arising from the diaphysis, most commonly in children. And clinical feature will be onion skin peel-like appearance. Chondrosarcoma, very old age, cartilage origin. Okay, Jane cell tumor, it's an osteoclast cells on origin. That's an epiphyseal one arranged. Okay, then we have something called soap bubble appearances on an X-ray feature. Okay, so this is certain other primary bone tumors. So one more important vascular pathology conditions like ulcers. Okay, it can be of an arterial or the venous or the neuropathic one, or neurological ulcers. Arterial ulcers, how do you identify? They are punched out in nature. They are very painful, and they have a major pressure like the distal pressure points. Okay, and on a clinical examination we don't have any pulse, and if the examination will be pale cold limb. That's an arterial ulcer. Venous ulcer usually secondary to that of most of the time varicose veins, where the venous ulcers occurs. Usually the gaiters area. Gaiters area is nothing but where above the level of a medial malleoli. Okay, because of the these conditions like lipodermatosclerosis or hemocytin deposition, the skin undergoes an ulcerations and develops a venous ulcer. They have a sloping edges and are very shallow in nature, and surrounding there will be a bluish hue with edema. Coming to the neuropathic ulcers, these ulcers usually occurs at the pressure points, like in the tip of the toes, okay, soles, heels. That's where occurs. On an examination, you will have a normal pulse. There is nothing, but they will be having very warm foot, okay, not like an cold foot, and this we see in case of arterial ulcers. Okay, that's a neuropathic ulcers. Again, these are the usually of occurs at the pressure points. So in the previous slide, we discussed about and the type of necrosis. Among them, the gangrene was also a type of a necrosis which occurs due to an ischemic event. So this gangrene can be of dry and wet. Gas gangrene is a form, again it is and the type of an wet gangrene. So what is dry gangrene? Dry gangrene usually occurs because of ischemia. If there is an obstruction to that of an arterial blood supply to the particular organ, so they will be having no proper blood supply. That undergoes ischemia, that undergoes an gangrene. Okay. So since there is no proper blood supply to the particular organ, so there will be an infections. The chance of infections are very low. There will be no microorganisms can be in present that particular organ, so that they will be undergo dry gangrene. The demarcation between the normal organ and the gangrenous part will be very well appreciated, and they have very good prognostic factors, and most of the time undergoes an auto gangrene, will be auto amputate. Whereas a wet example for this you can talk about and in the terms of diabetic foot. That's a good example for the dry gangrene. Coming to the wet gangrene, here it's the gangrene occurs because of the venous obstruction. So there will be a venous pool of the blood. So we have a very good pool of venous blood, which is a very good source for the development of an infection. So there will be infection occurs, and the chance there will be because there is an bacterial accumulation. So there will be a foul smelling spreading in nature. They have an high risk of development of septic shock. Okay, and it will be very highly contagious. They keep on spreading because of the enzymes. Okay, and that's very dangerous. They have a very bad prognosis. Example, involvement of an bowel wall in wet gangrene. Gaseous gangrene is because of if it is an involvement of an infection by an Clostridium perfringens group of an bacteria. So that leads to development of gas gangrene. Okay, so if you feel on a clinical examination, if it's a crepitus with a myonecrosis, goes in terms of a gas gangrene. Okay, which is of surgical emergency in nature. Then we have ischemia, thrombosis, and embolism. So what is ischemia? We know that there is a decrease in the blood supply. So what are the features which says the presence of acute limb ischemia? This acute limb ischemia can be because of thrombotic event or embolic event, anything. So acute limb ischemia can present with 6 P's. Either it may be pain, pallor, pulselessness, perishing cold, paresthesia, and paralysis. So all this shows a patient having acute limb ischemia. Again, it's a surgical emergency. Then we have thrombosis. What is thrombus? Thrombus is nothing but obstruction in a blood vessel. The blood caused by the component of the blood in a moving blood. If it's at the stasis blood, it's called a clot. If it is in moving blood, if there is a formation of the block by the constitution of the blood itself, then it's called thrombus. Okay, that will be fixed. That's called thrombus. Already we discussed that switch off triads. If there is any alteration in any of this presence of endothelial injury or the venous blood stasis or presence of hypercoagulable state, the patient have a chance of developing a thrombus. If the thrombus get dislodged and deposit somewhere else, then that event is called an embolism. Okay, most common like atrial fibrillation, neural thrombus formation within the heart. If it's get displaced and forming an CVA, acute kidney injury and all, it's an event of embolism. Venous can, in case of thrombosis, in case of DVT, deep vein thrombosis, because of prolonged immobilization or any undergone surgeries, okay, often lower limb. So that leads to a venous stasis. This leads to the deep veins, leading to deep vein thrombosis. The problem with this deep vein thrombosis, if the thrombus gets dislodged and goes to an pulmonary capillaries, that the patient will end up in having a pulmonary embolism. Okay. Coming to a thyroid carcinomas, we have the 4 main different types of thyroid carcinomas: papillary, follicular, medullary, and anaplastic. The few gist points to remember identification of these carcinomas. Papillary usually occurs in younger age group and they have a very good lymphatic spread. Okay. On histopathological examination, we have found typically known as orphan annii nuclei. They would have given this mentioned in histopath report. Okay, so that this is a cartoon picture which represents an orphan annii appearance. Presence of samoma bodies. Okay, all these features goes in favor of papillary carcinoma. Usually occurs at the younger age group in the females. It's a very good prognosis. Okay, we treat by doing a total thyroidectomy. Follicular carcinoma, on the other hand, they have an hematogenous spread. So they present with that of an head and neck pulsatile swellings. Okay, that's an important feature which is a patient having a follicular carcinoma of thyroid. So the vascular invasions are very high, mainly the head and neck region. That's the most site where the follicular mets can occur. Then we have the medullary carcinoma of thyroid, which is arising from parafollicular C cells. Here the tumor marker will be calcitonin. In case of papillary and follicular, it's a thyroglobulin will be a tumor marker to identify these tumors, whereas in medullary it's a calcitonin which is secreted by the parafollicular C cells. Okay, and usually associated with the MEN2 syndrome, multiple endocrine neoplasia 2, the medullary carcinoma of thyroid. Okay, along with your other features like your pheochromocytoma and as well as and the pancreatic tumors with the hyperparathyroidism, medullary MEN2 will be associations with this. Anaplastic tumor, very old age, where they have an highly aggressive nature, poorly differentiated tumors, very poor prognosis, will have an anaplastic type of thyroid carcinomas. Okay, in anaplastic type, we usually do one palliative care. Coming to certain endocrine pathologies like thyroid status and parathyroid 1. The enlargement of the thyroid gland is called as a goiter. The goiter can be of multinodal, which is of the most commonest one. It may be solitary nodal, which can be because of hypoplasia, or it may be because of an adenoma. Then there's something called Graves' disease. This basically Graves is most often functional thyroid disorder where they have present with an hyperthyroid status. Okay. Then all this, any benign thyroid conditions, we always evaluate with the often thyroid function test followed by an ultrasound. If you feel that if there is any pathology, underlying pathology present, and you have to confirm it further by doing an FNS, okay, or the biopsy. So coming to one parathyroid, hyperparathyroidism is the most commonly discussed topic, which is increased secretion of parathormone. As a result, what happens? There will be the alteration in the calcium metabolism, and even if there is an alteration in the calcium metabolism, so there will be more of bone defects. So coming to one, and the hyperparathyroidism can be of primary, secondary, and tertiary. The primary hyperparathyroidism most of the time due to an adenoma. As a result, because of there is increased parathormone as well as an increase in calcium levels. Secondary to that of a decrease in the calcium, there will be persistent stimulation of parathyroid gland to secrete the parathormone. Okay, so in secondary hyperparathyroidism, so there will be increase in parathyroid hormone, but calcium hormone will be decreased. Tertiary one, which is of primary, eventually becomes secondary. That's called as tertiary. Autonomous after the long secondary. For example, in case of following an CKD patients, the tertiary hyperparathyroidisms are very high. The clinical features of primary hyperparathyroidism, where there is increase in calcium depositions in different organs. Patient may have renal stones, pain in the bones, abdominal mons, and as well as psychic groans. So all these are the mnemonic for that you have to remember for the clinical features of primary hyperparathyroidism. So a small announcement regarding about upcoming event. So we have we're going to conduct for the exam of September 2026. We have 3 months regular course, so that you guys can join us. So this is going to start with the 16th June of 2026. So with this gist of some few stations, we are going to talk about and a certain few questions that can be arising from these stations in your pathology. Okay, so exam 1 question and answer session of 1. So there is a 68 years old man who has an ejection systolic murmur radiating to the carotids with a slow rising pulse with a narrow pulse pressure, and they have an episodes of syncope and all. So what will be the feature? Key features among this. So we have to remember ejection systolic murmur, old age, radiating to the carotids with a narrow pulse pressure with the syncopal attacks. The most likely the valvular lesion will be the aortic aortic stenosis. Okay, so the symptom triad, remember SAD. What are those? Syncope, S for syncope, A for angina, and D for dyspnea. The state 2 markers of the severe disease, as I said, when you do an echo, if you found that if the aortic valve size, if it is less than 1 centimeter square, the ejection force of the jet volume, the force of the blood across the aortic valve, if it's more than 4 meters per second, and the pressure gradient across the aortic valve, if it's more than 40 mmHg. So these are the sometimes 3 criteria to say they have a patient have severe aortic stenosis. The commonest cause in this age group, the 68 years old age group, it is because of the calcific degeneration, okay, of the aortic valve. In a younger age group, because of the deformed valves, the calcification occurs. That is in younger age group. The management will be the valve replacement. The valve replacement, again, I have to talk about this. The valve replacement can be of the mechanical valve. You can use a tissue valve. We have something called Ross procedure. Or if it's an emergency condition, we do what is known as balloon valvuloplasty. Mechanical valve, the problem with the mechanical valve is they always forms and sound, and the patient have an high chance of developing a thrombus. Henceforth, we should always supplement the patient with an warfarin anticoagulant. Patient should always under long-term monitoring since he is on the warfarin. And and it's easy to install in case of mechanical valves. Coming to the tissue valves, it's very good, and it's difficult to insert. The procedure the very advantages of the tissue valves are the patient will need not to be on the long-term anticoagulants. Okay, so henceforth the patient will need not to have the monitoring of the coagulation states every now and then. Okay, that's about the tissue valves. Balloon valvuloplasty, it's an emergency procedure where the patient should undergo whenever there's a severe aortic stenosis with the life-threatening conditions where that you have to overcome it. We can do one balloon valvuloplasty. Ross procedure is nothing but where we are going to the normal valve will be replaced or repositioned to form in the place of abnormal valve. That's known as the Ross procedure. Okay, that's how we are going to manage it. What is this AVR? It's an aortic valvular replacement. That's an installment or a valvular replacement. That's what you're going to do this other procedure. Then second station, there is a gastrectomy specimen showing a rigid, thickened leather ball stomach, histologically showing the cells which are nucleus displaced presence of intramucin. So name the cell type and the tumor. So leather bottle appearance with a nucleus being displaced, mucin deposition. So all this goes in the favor of cell type will be of signet ring cell type. The tumor will be a diffuse type of the adenocarcinoma of the stomach. Microscopic term, leather bottle, lintus plastica, what we call. Eponyms for the spread of the tumors, we said it starts from here, which of lymph node for the left supraclavicular group, or it can be around the umbilicus and the system many group of lymph nodes. Transthelomic spread in case of ovary to form Krukenberg tumors. So such a certain eponyms that you can, or in the pouch of Douglas deposition. Okay, so these are the certain eponyms which we use. Hereditary association, of course, in case of this gastric carcinoma, CDH1 involvement gathered. Okay, that's the thing. Intestinal type, interstitial, diffuse type has a very worst prognosis. Okay, coming to the interstitial type. Third station regarding about the skin pathology, where is a pigmented skin lesion, asymmetry with a irregular notched border, variable color. See ABCD criteria. So asymmetry, border will be regular, color variation, excision biopsy confirms the malignant cells. Presence of melanoma. So diagnosis will be malignant melanoma. What is single most histological prognostic factor? As I said, it's the breast loss thickness. That is nothing but the depth of an involvement of the melanocytes from the status granulosum. Okay, that's layer, that's the breast loss thickness. Route of and spread, as I said, malignant melanoma is both hematogenous as well as the lymphatic. It's a guide for the excision margin. Of course, it's a breast loss thickness. The fourth question is specimen of the bowel shows the stepwise change of normal mucosa to the polyp to the invasive tumor. The patient is anemic within the complaint of abdominal discomfort. So can you appreciate here the presence of normal mucosa to the polyp to invasive tumor? So there is a normal adenoma to the top and the carcinoma. Adenoma carcinoma sequence. So this is a pathological sequence. So staging system. So what we have used, most common, remember in colorectal cancer, it's a Duke. They have used a TNM also, but most commonly use a Duke staging system. So which Duke stage triggers a chemotherapy? I said the stage C, okay, where the nodal involvement determines the use of chemotherapy. So which marker uses in follow-up? So we use an chorionic embryonic antigen, okay, CEA as a follow-up marker. And why the patient have an anemic here, if at all, the right side involvement of the bowel is anemic. Left side of the colorectal cancer is present with the top and the obstructive symptoms. A intravenous drug abuser has a fever, new pansystolic mama, splinter hemorrhages, painful nodules on the finger pulse. See, so it's a pansystolic. It's an first one. The risk factor is an IV drug abuser, pansystolic mama, with the splinter hemorrhages and painful nodules in the finger pulse. So Osler's nodules and Janvey lesions, what they're talking about. So the diagnosis will be of infective endocarditis. Most common organisms will be Staph aureus, and in case of IV drug abusers, most commonly it will be Staph aureus and hack group of organisms. In case of after a dental procedure, it's in Streptococcus viridans. Which side of the heart involved? Since it's IV drug abuser, right side venous is the right side. Okay. Two peripheral signs, as I said, Osler's nodules, Janvey lesions, splinter hemorrhages are the peripheral signs. And clinical features, we have a narrow pulse. These are the peripheral signs. Why it's difficult to treat? Because the valve, as I said, there is a development of vegetations along the closure of the valve, which is of avascular, and the development of biofilm. That's the cause for this. Okay. Always answer like this. It should be a top point to point. You should not beat around the bush. So always have an the one word answers that gives you fetch your marks. Only the keywords you have to remember. So we have in live sessions too. If you want, you can. This simulates your virginal exams. So we have an simulatory exams online, on-site courses that you can 2 days live course that you can attend. So with this, I'm going to give some certain few things that you have to always do and never do. Okay, so we know that the malignancies, when you say how do you want to say the malignancies, you should say the based upon the ability to invade and as well as and the ability to metastatize. That defines the malignancy, not by the size of growth or the growth rate or the size of the tumor. Okay, then what is the difference between grading and staging? Grading is a differentiation, how well it's differentiated from the parent cells. Staging is based upon the spread of the tumor. Okay, and never forget the route of and spread of the tumors. Calling and ductal carcinoma in situ as and the invasive one. Okay, that's are the major blunders. In follicular thyroid cancers, we can't do an FNAC because it will be divided. Follicular thyroid carcinomas are determined only if they breach the capsule of the thyroid. So capsular breaching cannot be identified by an site FNAC, that we have to do on biopsy. Okay. Then coming to one and always make sure that you give an one-line definitions. That should be a top-notch point to point. Okay. Coda invasions, metastatic as a hallmark of malignancies. The route of and spread. What are the three prognostic markers in each case of stations? Like in case of breast loss and breast loss in case of malignant melanoma. Malignant melanoma, and nodal status in case of and the breast. Okay. So link a pathology to the management always. Mention the multidisciplinary team involvement wherever it's involved. Certain pulse, viva pulse, which can help for you. So the definitions, malignancies is nothing but invasions and mets. These are the same thing what we talked about. So tumor behavior, DCIS is a pre-invasive in nature. Breast thick nose derives a melanoma prognosis. Signet ring cells is nothing but lentus plastica determine the diffuse gastric tumors. Prostatic mets most of the time will be sclerotic and most other are lytic. In case of breast, it's a mixed one. Triple negative breast with no hormonal status with no response to one and the HER2. So that goes in favor of and the worst prognosis with has to be treated by a chemotherapy. And the Barrett's metaplasia where the squamous will be turned into a columnar one. It's a pre-malignant condition where the patient can develop an esophageal adenocarcinoma. Coming to one cardiovascular thing, remember about and the sad features for symptoms of an aortic stenosis. What are the features to say that the patient having a severe aortic stenosis? Then about an infective endocarditis, the causative organisms, and when the Streptococcus viridans occurs after the dental work, and what are the peripheral hand signs? What are the sites of an and the bony mets, primary bony mets, and what is about an pathological fracture, okay, and how you're going to grade it, how you're going to fix it. Coming to the GI skin endocrine, which of Krukenberg, system Aries, so these are the advanced gastric carcinomas. Duke-C states the patient should require an adjuvant chemotherapies. Basal cell carcinoma acts as a rodent ulcer, which is locally malignant. Squamous cell carcinoma, lymphatic spread. Malignant melanoma, both lymphatic and as well as an hematogenous spread. Marginous ulcers, squamous cell carcinoma in a chronic non-healing wounds. Remember, taken biopsy, think in terms of marginous ulcer. Papillary thyroid, lymphatic invasion, follicular hematogenous invasion. Papillary thyroid, what we have in orphan hyperions, follicular, on a clinical, we found that there is a presence of pulsatile bony masses. Okay, medullary carcinoma of thyroid, the tumor marker will be calcitonin. It's usually associated with the MEN2 syndromes. Keywords that help you for the diagnosis, like orphan hyperion, samoma bodies, it's a papillary thyroid. Lentus leather black appearance, signet ring cells, it's a lentus plastica, diffuse gastric carcinomas. Poorly rolled hedge with the telangiectasia, it's a basal cell carcinoma. Presence of Reed-Steinberg cells, Hodgkin's lymphomas, of this called as an owl high appearance. Okay, these are the chain cells. Coming to the Codman's triangle on X-ray, osteosarcoma. Onion skin periosteum, it's a Ewing sarcoma. Broad spots with the splinter hemorrhages, think in terms of infective endocarditis. Margiolis, the chronic non-healing as a squamous cell carcinoma. Punched out, painful, large pulses. It's an arterial ulcer. Saponification of the fat necrosis in case of caseous necrosis, case of tuberculosis. Narrow pulse pressure, edgeoxysystolic murmur to the carotids, and slow raising pulse goes in favor of aortic stenosis. Syncope, these are the sad features I already said. Bicuspid valve in a young patient developing aortic stenosis, development of an infective endocarditis can be occur. IV drug abuses with a new tricuspid murmur on the left side. On the right side. Okay, so that's in right side infective endocarditis. So the commonest will be a Staph aureus. Presence of Hossel's nodules and Janvey lesions. The breast tumors regarding about triple negative. Same thing which I talked about, the adenoma carcinoma sequences, it's very important. Then mainly the telangiectasia on the face basal cell carcinoma, excisions and most criteria what do you use it for the excisions. Chronic burn scar, ulcerative and gross squamous cell carcinoma. So coming to the definitions, malignancies, it's a capacity to invade and metastasis. Grading versus staging. Grading is the level of differentiation. Staging is the extent of spread. Route of spread, 4 routes, very important. Why infective endocarditis are hard to spread? It's because of biofilm as well as presence of avascular valves. Most important melanoma factor will be bacillus thickness. So these are my sources for further reading if you want. Always have an updated nice guidelines. Okay, it's very important for you to upgrade, and these are the certain standard books that you can follow. Okay, so that's being said. We also have an upcoming event of 1-to-1 mentorship for the part B. That also you can join us with the Steady Medic group. Okay, so I think no discussion a lot in this group. So with this, I'm going to conclude the session. So if there's any doubts, please let me know in the comment section.